By the way, okay, so I'm a neurologist. I do other things, but this is one of my clinical or research interests. Do we like pot or ot? I like...
Okay.
But then you sound like an occupational therapist.
I know, we do.
Ot. It's just a...
Okay, call us pot.
It's a lower Scrabble score as well. Anyway, I call it pot. Just always have.
Yeah.
Because,
yes.
you know...
We kind of just dropped it.
I just don't know, yeah. Okay, so I was asked to... I was around in 20... Was it 15 in Sydney? 13.
13
in Sydney.
Wow. Oh, blur. So I'm supposed to be giving all the latest updates since 2013, which will take about 5 minutes. There is some new stuff. Oh, hang on. So if you're going to Google things, by the way, I haven't put this up, but don't go to... Like, blogs are fine and they're great for support. It's really awesome that you can support each other in a blog, but just be aware that you could write this down, it's not here, PubMed is all the publications from 1966 in peer-reviewed journals. So generally, if it's published in PubMed, you can sort of believe it, although people will question that. Depends on the quality of the research. So yeah, I did a movement disorders fellowship some years ago with some really good people who have now left. Some of them are still dabbling in research, but others have retired. But it was good quality research, just starting with a really simple premise that medications, so orthostatic tremor have been around since 1984. The main medication that had been used until that time was clonazepam, which is arguably just anxiolytic or calming. So it reduces the phobia of falling, presumably. No one's actually ever done a clonazepam study to see whether it reduces tremor or body sway. But you know, I use it a lot for a variety of tremors, and I think it's mainly just to dance down the any tremor will worsen when you're stressed. So clonazepam will just take the edge off that bit, which can be very sedating. But anyway, it's still useful. People with OT are often on a cocktail of different things, a little bit of this and that, and I use a little bit of that, clonazepam. Okay, so did a bit of research, and then fast forwards, as Sue said, I now work at I love the title of my... everyone asks me, so some people over... Peter Silverman was over last week doing a case with us. And everyone wants to know, well, it's called Hollywood, no one knows. But I know, I love that I work in Hollywood. It's not just me, I have there's a neuropsychiatrist, so if I have a patient with OT or anything where there's a significant component of anxiety ruining their quality of life, you must involve another doctor. And the guy in the middle is a neurosurgeon. I wouldn't not do DBS. No one's asked me. It's a quality of life thing.
First customer? No.
Chef, where are you from?
Adelaide.
Yeah, get someone there to do it. Yeah, if your quality of life is significantly impacted, you should consider surgery, and I'll go over the surgical data. There is a little bit more data than 2013. I stopped doing research because I wasn't supported by institutes, it's just too hard. You can't do research solo, but I've just discovered that there is a study coordinator at my hospital, just discovered it this year, so we're doing a small industry-funded tremor trial for some new drug for essential tremor, for example. And immediately, people will want to try, if it comes out, they'll try for other tremor syndromes. That's what happens. Every new anti-epileptic drug, just try it on tremor, just give it a go. Okay, so the talk outline, I have to include all the preamble because some of you might not have heard the original talk about what we understand of OT. Do I have a pointer? Let's use this. Right, doesn't matter. And broadly speaking, there's lots and lots of descriptions because researchers find it fascinating, and you can just do all these different studies that may or may not eventually help people, but some of them have. And then there's research looking at different new therapies, so that's good. Nothing worse than getting a lot of descriptive papers, just detailing your disease, and then it goes nowhere. So there's a group in Munich should go visit them. They've got some good stuff. So it is a weird condition. You couldn't design a more annoying disease. It's invisible. You sort of get up and you can't understand why you're unsteady, and the descriptions I've got vary from, my legs are shaky, which is pretty obvious, to I feel panicky, I'm going to fall over, which is not specific, and then you have to disentangle the phobia of walking and standing and social anxiety from the actual physiology. And then you just do the EMG test, electromyography. I've got a little portable one, show you later. But yeah, it only happens when you stand, and it worsens the longer you stand, and the symptoms improve or disappear, not in everyone. Apparently if you walk up steps. Does anyone have difficulty? So of the people in the room with OT, how many people here, put your hand up, would you say your symptoms disappear when you walk? Disappear, okay. What about when you're standing on one leg? Like walking upstairs, sorry. Walking upstairs, is that hard?
Downstairs.
Downstairs. Okay, but for the people who say the symptoms disappear when they walk, keep your hands up. So if you don't have trouble walking downstairs, keep your hand up. So stairs seem to be a problem. It's because you're spending more time on the standing foot. There's a really good study that outlined that. Yeah, so lawn bowls, I would imagine.
Yeah, lawn bowls.
Got a lot of patients who have to give up lawn bowls. Yeah, and it's really unimpressive to see. It's an invisible disease. And you can look at all sorts of disability scales. It's as disabling in some cases as Parkinson's. People use wheelchairs. So yeah, I'm a DBS fan of DBS. I think more people should consider it, but we'll get to that. I understand why they don't. All right, yeah, so non-specific disequilibrium is one of my favourite it's a term you use when you're just not sure why someone's dizzy or unsteady. Psychogenic is flat out, well, you can have like an anxiety disorder around dizziness, but some people get phobic of busy environments and other things, and this can be, co-diagnosed with OT, so it doesn't have to be separate. And yes, it's really good to see that there's someone talking about psychological approaches to managing tremor. This is just one of the papers from these guys are pretty well known. Movement disorder specialist, 40 patients from France, so French get OT as well. I don't know what grounded theory approach is. Sue's cleverer than me, she should know all this stuff. Fear of falling was identified as the main predictor. So most people don't fall, but if you spend all your life worrying about falling, that's not fun. So it's called triple F syndrome. Actually, when someone falls and then they have a fear of further falling, that's triple F syndrome. I don't know what you call it in pot. Never fall in triple F. I mean, some people do fall because you get tired.
Very fatigued muscles.
Yeah, but in general, it's a fear of falling rather than falling. I've not seen a lot of, I've got more Parkinson's patients or cerebellar ataxia patients with fractured wrists and hips than OT patients. So yeah, health-related quality of life, bad. This is the one and only video. So this is a lady who was about to stand up. This is about 15 years old, this video, but this is a nice machine. It's nice and loud. You'll see the patient stand up and then eventually sit down, and then you'll see the EMG bursts on the screen, and then you'll see the EMG bursts of a normal, non-OT patient's legs. So I can just play. Through.
Yes.
Yeah, it's on.
So I can hear that knocking noise. when you activate a muscle, normally you just get that envelope, whereas in OT you get the so that each of those squiggly line going up and down, that's the electrical activity of what you call a tremor burst. Whereas normally with a normal muscle activating, you just get a wave. So yeah, it's relatively easy to diagnose. Once you've thought of it, it's a problem thinking of it in the first place. And you get people turning up in balance clinics.
Oh dear.
So secondary orthostatic tremor. This is someone with Parkinson's. I've still yet to find a cause of OT. We scan everyone from head to toe, do all sorts of blood tests, and rarely it's reported with MS or this, that, and the other. But still haven't found anyone with structural cause. But this is an orthostatic tremor due to Parkinson's disease. You can see it's wildly different from the previous lady. I didn't measure his tremor in his legs on and off, but obviously it's better. So he's still not perfect. His legs are still shaking when he's walking, but they're shaking less. And other than his tremor, he's pretty good. That was 10 years ago, though. So what's the origin of this strange tremor that, it's not just activated by standing up. You think it's some verticality detector, but if you push on an object, you'll get tremor in the hands in some cases, or if you lie down and push on someone's leg, you can measure the tremor. So there's other different theories of what generates it, but from top to bottom in the nervous system, everything's been implicated. Of the animal kingdom, Great Danes seem to get it, but that doesn't really help us. So you can YouTube videos of dogs just trying to settle, and they have orthostatic tremor. And bulldogs have head tremor. I've got French bulldogs, so I know about bulldogs. Get your bulldog stressed and it gets this 10 hertz head tremor, which has also been published in the Journal of Movement Disorders. I love it. This has not been published in a human journal. Just to be vague, it originates somewhere in the brain or spinal cord. Somewhere. I shouldn't make fun of it, but everyone's trying to pin it down. It's not. There's no such thing as one. The brain is a network, so people should just give up looking for the holy grail of one spot. And who was saying this about Sue was saying something about different symptom sets, and not everyone with OT is the same because it's not a disease, it's a syndrome. So there's different forms of it, but we're just describing it. We don't have pretty pictures in everyone just know exactly what's going on. And the fact that one person will respond to gabapentin or not, or any drug, or deep brain stimulation of the same target, it just tells you this can't be the same. It's a network that goes wrong. There's probably different, hotspots within that network in different patients. We know this from essential tremor. That's the commonest cause of tremor in humans. Totally different. Starts off in the hands, although some patients with OT can have a bit of hand tremor, or more than a bit. ET is a syndrome as well, and they can't quite pin down where in the brain that's coming from or which gene. So just pull back and try and understand it from what's going on with postural control and where does that feed in. So obviously we don't think vision's the problem with OT because eyesight's normal. Although if you close your eyes you can get worse tremor and body sway. It's one of the ways we measure it. The vestibular organ, the inner ear, again that's not implicated, but it doesn't help if you get that, go off and get a bout of vertigo or have inner ear problems, Meniere's or something like that. So if you do have any of this stuff, if you have poor vision, if you have cataracts, get them fixed. Don't ignore vertigo because it's an additional cause of the fear of falling. The legs themselves, obviously they're innocent. They just wobble. But then someone's gone and tried to blame the legs. So in the leg so there's a really cool little device within the muscle called a muscle spindle. And it's got this tight little coil it's like a little tension detector. And that's been implicated in part because if you push on something, the muscle spindle feeds back muscle tension, and that sets up this feedback loop. This is the feedback loop for a reflex, the old knee jerk, for example. So one of the theories is that, the longer you stand, the muscle spindle set up this resonant feedback loop, and then just drives this tremor. But I don't think the spindles I think they're innocent. And you don't know what causes the unsteadiness. Victor Fung's study is coming up that'll highlight that. Okay, so there's no gold standard for measuring it. There's the subjective things, the quality of life and all that sort of stuff, and falls, anxiety scales and balance confidence scales, all those things exist. You can measure the body sway, the wobble. Hopefully the force platform will work. It didn't like the trip over, tried to set it up last night, but we won't be able to fix it. So that's a computerized balance assessment, tests body sway and balance control. You can measure the tremor, but that's the problem, because you saw before that lady, that was her rocking back and forth. So depending on how much weight you bear on which muscle and whether you're doing this or not, you can't measure tremor exactly. It's sampling bias. So the force platform's nice because I think it just captures all the forces in XYZ plane, and then you measure it with different stats. This is the ellipse around most of the data. So you leave out, this is just someone having a bit of a wobble. You don't want to include all that, but you get a number. So this is someone where their sway area was 10 centimetres, and after treatment with, in this case, gabapentin, it was like 30%. And then this noisy looking graph here, if you blow it up, this is the frequency on the bottom, and the size of the tremor or power. So yeah, you can measure this just all off the force platform. Otherwise you have to stick on electrodes, and trying to wire someone up with electrode, which we did, just reduces your balance confidence even further if you're wired up to all this stuff. But there are people who have wireless things, so that's nice. So you saw this already. In case you're wondering, this is a control person. So yeah, it's quite a lot more sway, and this is just when you're just standing with eyes open. So you can imagine and this is only for, I think it's only for, I forget if it's 20 or 60 seconds, but just imagine yourself, if you have the condition, when you're in the second minute or the third minute, where this is building up and the feeling of unsteadiness is ramping up. So this is what Victor Fung about 20 years ago did this study that just confused everyone. So the patients were all wired up. They were on a force platform. They were measuring body sway. They were measuring the electrical activity in a number of muscles. So good on patients for actually doing all this. And in addition, they had this little device that they were holding that they racked up the start, mild, moderate, severe. So this is their degree of unsteadiness. And they tried to look at the correlation between how unsteady you feel the longer you stand. Let's just say that's a minute or longer. And you see the tremor starts low and gradually ramps up. And that's consistent with what you see in some people. If there is a visible tremor, it's really quite bad by the end of the stand and the trunk's involved. But the wobble doesn't change. So no one knows what that means. So there is something that is generating unsteadiness that appears not to be, ramping up body. It's not like it's all over the place here. That's an artifact. But tremor is increasing. So again, people wandered off and made all sorts of theories as to what it all meant. But I was mainly focused on measuring things and seeing what gets better when you treat people. So along with the statics down here, you can do these fun tests where this is a bird's eye view of someone standing like this and having to lean this way and that way. It's not a very... What?
I remember doing that.
Yeah, it's not a very... It's not a practical day-to-day thing to do, but it does test your limits of stability. So the worst direction is backwards, and it doesn't test postural responses, which is another important thing to test. But there's other gadgets which will test that. This is all. This protocol was designed to just test people within the shortest amount of time possible with the least amount of gadgetry. That's why we came up with this way of doing it. So you get all these measures of, well, they wobbled this way and did they overshoot the target, and then you test drugs. So clonazepam we mentioned, all the problems of it. You can also lose benefit over time. There's a whole bunch of, this is not an exhaustive list. They're mainly dopaminergic medications, which we don't really understand because people do not go on and develop Parkinson's disease. It's not the start of Parkinson's disease. I've had one patient that after 20 years developed Parkinson's disease that she was also in her 80s. So it's just a common thing to happen. You can get a rare disease and a common disease. There were some case reports of gabapentin being useful. Don't know, I can't remember how that came about, but I'm sure it was the usual. There's a new anti-epileptic drug, let's try it on tremor, so that was good. Because it seems to have been a useful drug in some people, so we did this double-blind trial. So the problem with trials and getting them published is that you have to do a placebo arm. But of course we had people who were on it, and you take them off it. It's not very blinded when it's working. I mean, there were two I think there was 6 patients, 2 of them were treatment failures, so that's why you do it. But it's a hard thing to do. You need drug company support. For this one I was hand-filling all the little capsules myself and just can't do that anymore. Anyway, that was good because we got it published in a proper journal, Movement Disorders. And lots of pictures, but basically the bottom line is this is baseline and this is improvement. So there is some improvement in the sway area and the tremor and everything else to an extent, but there's still not normalised. So in this quality of life scale, it's adapted from a Parkinson's one. 0 is like perfect health, and there are questions like how did you go getting around the house or doing the dishes, and there's some screening questions in there for mood and stuff. So the blue line is actually on treatment. So even with treatment, there's issues, but not to say that gabapentin's a cure or anything, but it's useful, but people still there's more to do in terms of non-drug approaches. So again, this is ages ago. Gabapentin, I still use gabapentin and I switch back and forth depending on people's tolerance and response and add in things. I've never used gabapentin and pregabalin because they kind of wouldn't make sense. They act on the same receptor. So this is just a tiny, tiny study of comparing Lyrica versus gabapentin, and I could show you slides that go the other way, where patients who just can't tolerate Lyrica and go back onto gabapentin, or not back on. In general, Lyrica has more side effects than gabapentin. So there's just one patient who was a winner. She was very happy that Lyrica arrived because she was on a big dose of gabapentin. 2,000 to 300 milligrams is a big dose. 900 a day is just a starting dose. But yeah, look, so this is with her swaying all around the place and with her eyes open. So this is gabapentin, this is Lyrica. This is with her eyes closed, it's same data. And for some reason we had a researcher who was getting people to do this distracting cognitive task. And I was looking at it yesterday thinking, it's actually the Stroop test, but you could do the same thing getting people to stand there and count backwards by sevens from 100, serial sevens. If you have Parkinson's disease and you do this kind of cognitive task, you kind of sway more, and if a Parkinson's patient is walking, they shuffle and freeze more. But weirdly, like, I know there's only one person, if you distract someone with OT who's just standing there, their sway is less. So I don't know if it's, but that's the opposite of what people say. Like, I can't stand there and so having a conversation, which is arguably a distraction. Does anyone think that if they can distract themselves, they can balance better? Mind over tremor? Anyway, so I don't think that was real, but it's something. It's just data. It's interesting. I don't have an explanation. Okay, and sorry, that was the tremor power. Tremor was less, but also the sway. That's the sway data. So there you go. Another unanswered question. But I like this. Pink is pregabalin. Pink. Green for gabapentin. So yeah, the squiggly lines that are pink showed that the tremor bursts improved. So we were all pretty stoked with this. Went over to Kyoto on a junket. Ate lots of amazing food. Presented a poster, and I thought, oh, we'll just go publish it. So I wrote it up. You take all the time and effort, and they didn't like it. So there's still nothing. You can still find nothing on pregabalin if you PubMed it, Dr. Google it. And then I went to